Obviously, thank you so much for joining us for this event. So this is Ask a Cardiologist with Associate Professor Arthur Nasis, who's kindly donated our time, and it's part of the Supporting Young Hearts program, which is an initiative we run through the Heart Foundation. So next slide, thanks, Jen. So first of all, we'd just like to acknowledge that we are broadcasting across many traditional lands today. We pay our respects to all traditional owners of these lands and to elders past, present and emerging. So welcome. We are really happy that you could join us today for this event. My name's Pauline and I'm a Heart Health Coordinator and I work at the Heart Foundation supporting this program. Now, just first of all, a few things just to let you know. This webinar is going to be filmed and we will be publishing it on some Heart Foundation channels such as the website. So if you don't wish to be filmed, which is completely fine, just turn your camera function off. We also will be having breakout rooms, but we won't be filming those. Now, this event is for you. You told us you wanted to hear more from health professionals, so here we are. And we're really grateful for the questions that you guys submitted as part of the survey that we sent out. There were some amazing questions. Now, unfortunately, we obviously won't be able to get to every single one of them, but we'll endeavour to actually send out a correspondence pack after the event with the questions we weren't able to get to, and also just some references from the Heart Foundation and information that you might find useful. Now, we have the chat function, which some of you have already used, so feel free as we go along, just pop in your questions. And if you're not speaking, if you could just keep your microphone on mute, we'd appreciate that as well. But lastly, you know, as a group, there's no judgment, and we appreciate the fact that you guys have your own unique experience. So just remember, this is a safe space. So we have lots in store for you today. We have the opportunities for you to connect with each other in breakout room sessions. We'll talk you through the Supporting Young Hearts program, and then we'll jump into the Q&A session. So we're incredibly lucky to have these three individuals join us for today. So firstly, we have Geoff, who will share his experience as a young heart patient and as a doctor. We've got Cardiologist, Associate Professor Arthur Nasis, who's kindly agreed to answer your wonderful questions that you submitted. And we've got Ange Foster, who is a Supporting Young Hearts Advisory member, and she's actually going to host the Q&A segment. So we'll get to know them all a little bit more later on. But first, I just want to introduce you to Jen, who works with me at the Heart Foundation as a Heart Health Coordinator, and she works on the program as well. And she's just going to talk you through the Supporting Young Hearts program.
Hi everyone. So yeah, as Pauline said, I'm Jen, and some of you might already know me anyway. Jen Conway. I work at the Heart Foundation, but I'm also one of the admins on the Facebook group, and I know have spoken with probably a lot of you as well. So basically, we're just going to go through very quickly the Supporting Young Hearts program for those of you who don't know about it. Basically, the program is aimed at people aged 18 to 45 or somewhere thereabouts who are living with a heart condition, had a heart event, recovering from heart surgery. It's really, we wanted to help younger people like yourselves connect with each other, connect with the Heart Foundation, connect with health professionals and resources and programs, and to provide opportunities for you to support each other and provide relevant resources to help you manage your heart health, I guess. And the Supporting Young Hearts program is overseen by an advisory group of dedicated and awesome young people with a lived experience. We've got a few of them at the event today. So we've got Ange, Claude, Nicola, Goran, and Marcus, and hopefully you'll get to meet some of them in the breakout rooms. And a big thank you to all of them for all of their time, their effort, and everything to do with this Supporting Young Hearts program. We really appreciate it. And we've also got Mel and Alicia, who unfortunately couldn't make it today, and they're also on the committee. So moving on to how can the program help you? So I guess there's a few elements to it. It's really around helping you connect with others so that you can know that there's others out there going through similar things as you, similar conditions, similar experiences, and be able to connect with people based on that. It's very focused on storytelling, about sharing stories, whether they're blogs or stories we post online on social media. We've got videos, you know, even just posting things in the Facebook group are sort of like little stories. And then it's around support. You know, emotional well-being and health is a big area that comes up for your group of people, your group of heart patients. And so it's providing things that are going to help with your emotional health and recovery, and also managing, your condition and managing your recovery. I think that's also, we hear a lot of things from people, from young heart patients, that, that it might be that the medical professionals that they're dealing with, you kind of have a consult or something, and then you go away and think, oh no, but what next? And what else is there? And then you might not have an appointment for a while. So, people told us that, they wanted to know if they can travel, if they can go scuba diving, if they can go through metal detectors at airports, about their medications. Will they be on them for the rest of their lives? Or how long will they be on them, and why are they on them? Fertility options and family planning and returning to work and getting back into exercise. So these are just some of the things that people have brought up, and we're really trying to help you all connect with each other and with relevant resources and professionals to be able to, talk about these things and find answers, I guess. Answers is one of the things. So then basically, what does the program have and what resources are there for you? So if you haven't already, check out our webpage, which is just up the top there. Sorry, this is a bit of a busy slide. But the elements of the program that I'm just going to talk about quickly is that we've got the Facebook group, which I'm sure probably most of you are already a part of. It's a closed group to offer peer support, encouragement, advice, just meeting other people. It's a great group, and I'm sure everyone who's on it actually finds it really, really useful. And from what we've heard, they definitely do. We've got a video series of young people, and Claude, I believe you're in that, and a few of our advisory group members are in it. And yeah, it ranges from things, they're telling their story, sharing their experiences. There's stuff about recovery and rehab and lifestyle changes and words of wisdom, where their life is now. So it's a great resource if anyone is interested in checking it out. We've got a lot of story sharing, like I mentioned, which is partly the videos, but also sharing blogs, communicating via social media, people telling their stories and sharing them, and, helping others connect in and knowing there's others going through similar things to what they are. We've got regular events which we're holding. So our last event was the emotional wellbeing event, and then obviously we've got this one today, and we're hoping to continue on with more events. I think having this virtual platform now is, makes things a little bit easier. We can reach a lot more people. So it's an important part of the program. So having some information that you wanted and asked for, but also having time, which you'll see later on, to actually connect with other people and meet other people with similar conditions as yourself, and to help with that support. And then we also offer tailored information, health information, depending on what conditions and things people and backgrounds or issues that they're going through. We can put together tailored information for people that might be relevant. So that's just a little bit about the program. And I will send an email to everyone afterwards, with the recording of this and with some of these links as well. And so you'll have my details, and please feel free to reach out at any time. But next, we're just going to do a quick activity. So just going to, Kelly is going to randomly allocate everyone into breakout rooms. So this is just the first of the breakout rooms, and then we'll do another one at the end where you can actually go by condition and maybe meet some people who've got similar conditions as yourselves. So yeah, in your breakout room, it's just going to be for a few minutes. Maybe just have a little think about if you have been part of the program. How has it helped you with your heart journey? Or meeting other people, or something that you found to do with the program. So I'll give Kelly a second to do that, and then yes, we will be seeing you all later.
Jen, just let me know when you is this like a 5-minute type thing? Oh, I can't hear you. I can't hear you because you're on mute.
Yeah, you can bring everyone back now.
Now?
Yeah.
I'll broadcast a warning message.
Hey, Cal.
I feel like we should have some music playing to like while everyone's waiting to come back in.
A little dance.
I know. Only like on hold music or something.
Just sing along. Do, do, do,
Yeah.
do, 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 do.
No one wants to hear my singing though.
No one wants to hear mine either.
I'll give it a minute. Oh, what's that? I can hear is that Fleetwood
Who
Mac?
can guess it? Yep.
Reminds me of that guy, was he boarding down, the famous guy?
You got a car out of it.
You got it, I saw that.
Yeah. And he got sponsored by the juice company that he was drinking, the cranberry juice.
Yeah. He's done all right for himself, hasn't he?
Yeah, they sent him a truck, didn't they? They sent him a truck because he was using the skateboard to get to work. So they sent him a truck,
Yep.
plus a truckload of cranberry
right.
juice in order to get to work. Yeah,
That was nice.
pretty
So
true.
that was kind of just a little bit of a sample for you guys, because what we're actually going to do later on is actually, do breakout rooms for a bit longer, but we kind of just wanted to show you what it was all about so you could kind of get your head around it. So first of all, now what we're going to do is I'm going to introduce you to Geoff, who I think most people probably might have seen before. So he's a Supporting Young Hearts member and also a Heart Foundation ambassador. He shared his story as part of the Hand on Heart campaign, and he's had now 3 open heart surgeries, and he's currently in his medical training, his 3rd year, I think, basic physician. You can correct me if I'm wrong, Geoff, at RPA in Sydney. And he's on a pathway to become a cardiologist. So we thought it'd be really good just to hear from him, his unique perspective from, being a young heart patient, but also being a cardiologist, and then open it up to if there's anything that you guys had to ask him, just to either pop it in the chat or we'll have a few questions at the end.
Thanks, Pauline. So yeah, I guess in summary, if you haven't seen the video, in more alternate, way of describing what I've been through is that I was a normal kid growing up, and I had no idea that I had any problems, and was a fit young guy and exercised a lot. And at the age of 24, my aorta, which is the main vessel which climbs up around through the heart, ruptured. And so I had to have emergency heart surgery about 40 minutes after I first heard that was happening to me. So there was no time to waste. And then I recovered, luckily, thankfully. I mean, there's a very small chance of having recovered from that. About 40% of people don't make it to hospital, and of the people who make it to hospital, about half of those again survive the surgery. So pretty lucky guy. And then I committed post-surgery. I was originally doing economics and living in London and doing other things outside of medicine. And after that surgery, it was really, I remember the moment specifically when I decided that I wanted to do something different with my life and commit it to trying to save others in the way that my life was just saved. So laying in my hospital bed, I decided I'm going to become a cardiologist. This is what I need to do with my life. And so I committed from then on to study medicine. But then 8 weeks later, I had another dissection, which then ruptured both the arch, kept going up around the arch, and also the first one went through my valve. So I have an aortic valve, artificial aortic valve, and I'm on warfarin blood thinners lifelong. So the second procedure ripped up through my head and neck vessels. So I've got stable dissections, which are basically splits in the arteries of all the head and neck vessels leading to the head. And then I recovered from that, luckily, with all fingers and toes intact. Again, it's a single digits chance of having survived without any deficits from a second procedure like that. But anyway, I did and got into medicine eventually. And then 2 years ago, literally at St Vincent's, which is about 200 meters down the road from me, I was admitted with my third dissection, but this time the coronary artery, the main artery, which comes from the heart, leading to supply the heart muscle itself, was starting to burst. It was already in a hematoma about that size. So you can imagine a hematoma that size sitting in the chest. Because I was on blood thinners, it was bleeding basically. And that was kind of slowly leaking into my chest. And so I had a third open heart procedure then, which basically took out that hematoma, that big clot of blood, and here I am. And so, as Pauline said, third year basic physician training, which is the general training you do before becoming a cardiologist. And next year I'll be doing what's called an unaccredited training year in Coffs Harbour, in sunny Coffs. So here I am. I'm lucky to be alive, very much so.
That's amazing.
Yeah, it is an incredible story. It's I suppose from my perspective, has anyone got any questions they want to jump in and ask? Or there's lots of comments, incredible story, you rock, and the fact that you've sort of changed your career, where it is wonderful. And I think a lot of people here on the call and in the Facebook group have shared the fact that they're really excited that someone that's been, I suppose, in their position is actually going to be a cardiologist. So what do you think, I suppose, you've learnt from being on the other side as a patient that you've sort of taken into practice as a doctor?
Look, I think as a patient, and I'm sure we've all been there, so you understand what it's like, but you're spending 24 hours a day in hospital waiting to be seen by a doctor. And then the 5 minutes comes along, your doctor rocks up at the bedside, and then poof, they're gone. And then you spend 23 hours and 55 minutes the rest of the day waiting for tomorrow when the doctor comes back. And so that's hard for patients because, and I don't think doctors realize how hard that is for patients, because if doctors and medical staff in general had more time to sit with patients and really discuss, rooms like this wouldn't be necessary. If doctors had more time to sit there, hear about their fears, hear about their, really break down what's happened to them, discuss the pathology, draw it out if needed. I think that would create and alleviate a lot of the anxiety surrounding the diagnosis and a lot of the anxiety around the uncertainty of being a patient in hospital, because there's so much uncertainty. You get ruled off for a scan, you don't know what you're going for, you don't know why you're going, you come back, you don't know what the result was, you might find out tomorrow, might find out the next day. But despite that, I think what's important for patients to know is that the doctor has seen your results and is acting on them. Whether they've updated you or not, they're acting on them and they're thinking about the next step. And sometimes they don't want to come back to you with the answer or with the result because there's already another step being planned. They want to come back to you with the consequence. If that scan means you need surgery, they want to go and speak to the surgeon so they can come back to you and say, hey, you need surgery, but this is how we're going to do it. So it's being a patient and a doctor, you can kind of see both sides. And I do adjust my practice as a doctor. I make sure at the end of the day that patients know what they're here for, why they're here, what the scan shows. you know, I don't mind coming back at the end of the day and updating them on, you know, the results of the scans from today, and spending, if I can, more than 5 minutes with patients to really understand their anxieties. So that's a unique perspective I can offer on both sides, and yeah, and I'm thankful for that. Does that really answer the question?
Yeah, I was going to say, has anyone else got some questions?
The chat, mate, has, what's going on there? Oh.
Can I just say something, Pauline? Geoff, that's just an amazing story. And I really think that you have the potential, and I'm sure you will be an amazing advocate for other people, because, you know, I don't know of anyone who's been through as much as you, who, you know, is a doctor, let alone will be a cardiologist. So, you know, I'd love to sort of see you talk to some of our colleagues about that, because I think you really would be able to offer a unique perspective that a lot of us probably don't consider and have definitely not been through. So, you know, personally from me, you know, you're really inspirational. And I think, you know, I really look forward to seeing you progress through your career, because I think you've got the potential to touch many, many more people than most cardiologists out there right now.
Oh, thanks, Prof. That's super generous, and I really appreciate that. I feel like I do have, I'm lucky, and I do consider myself lucky at the end of the day. You know, not many people survive one dissection, let alone two, let alone three, and live to tell the tale, and then become a doctor, and then become a cardiologist. And so I think that, yeah, I'm lucky. I consider myself lucky enough to be in a position where I can, you know, educate patients and colleagues alike, for sure. Yeah. It's a unique perspective.
A question here, Geoff, about the emotional recovery after such big events, and I think that's something that a lot of people do talk about. So, what are, I suppose, your tips for that, and how you that?
I think after the first procedure, I was actually a bit naive. I was 24. I didn't really understand what just happened to me. It was all such a whirlwind. You know, I had the pain at 10 p.m. one night, and I'd had surgery, and I was awake in ICU, you know, 12 hours later, 11 hours later. And so that was all, I didn't really have time to be anxious. My third procedure, however, was significantly more anxious, and I was significantly more troubled with the diagnosis and how it would play out, because I had so much more to lose. All I wanted to do in my life, you know, post the first one, was become a cardiologist, and I was kind of in physician training, and you know, a step closer to doing that. And I'd had a partner who I was, you know, deeply cared for, and, you know, in my mind, it was all about to become crashing down. So how did I cope? Family and friends. You really, and I've heard this before from other colleagues and our patients, you really find out who your friends are after one of these events. You really find out who wants to know more, who wants to support you, who wants to be with you, or who doesn't want a bar of it. And either they can't handle it for personal, emotional, or they just want somebody who's healthy and happy and not going to burden them with their problems. And so you really find out who your friends are. And in some ways, that's kind of good, because some people go a lifetime not knowing who their friends are. And for us, we found out that in an instant. And then you really hang on and can really rely on those friends who've stuck around. And so utilizing them and using them to be a support network, both for yourself, physically, mentally, and emotionally, and your family. But, you know, I mean, it goes without saying, psychology and psychiatry requires, certainly. But I think not enough can be said about exercise and eating well. Cardiac rehab. I actually didn't go to cardiac rehab after my first and second open hearts, because it wasn't offered. They didn't say you should go to cardiac rehab. But after my third one, they said you should go to cardiac rehab, and I thought, fantastic. You know, that's a great idea, because I can, you know, if shit hits the fan, it's gonna, and it happens in a hospital, great. You know, that's the best outcome. So I thought, why not try to get an exercise program that's graded, that I can, you know, be supervised by the right people. And so that helped with my mental health, and also my physical health. It allowed me to have an insurance policy of seeing how far I could push myself, my body, on a regular basis for 6 weeks. And so I found that really, really therapeutic. And also for me personally, the final thing is that I realized after my first procedure what was important in my life too. It really drilled down in my life. It got rid of all the unnecessary bullshit, excuse the language, and you really focus, you really get a good understanding of what's important to you, you know, and just, I realized the 4 things that were important to me after almost losing my life once were music, travel, family and friends, and now medicine. And so I use, each time I've used that, and even as I get home from my day, I'll put some tunes on, you know, or I'll book a ticket for another gig, obviously not at the moment, but, you know, in normal times, or a trip domestically or internationally, because traveling for me is a big thing. And so I always make sure every day I'm thinking or somehow planning something that relates to one of those 4 things. And that keeps a really good mood, really good level of positive thinking.
They are really good tips. Has anyone else got any other questions? We will get Geoff to jump into a bit more of a Q&A later, but if there's anything else anyone wants to ask.
I did have just one quick question. I know we've got a pretty stacked agenda, but Geoff, something I hear quite often too is that people don't get referred to cardiac rehab, or they might miss out, they might not even know about it. So looking back on your experience, what do you think could have been done differently or suggested to you the first time round?
Yeah, good question, Ange. To be honest, slap on the wrist for doctors who are not referring their patients to cardiac rehab, because it's in the guidelines and it has proven to improve outcomes. Yeah, it should be a blanket referral, irrespective of your stage. What we call you might have heard the New York Heart Association classification, which basically is an assessment of how well you are and how short a breath you get from 1 to 4. Irrespective of your class, I think cardiac rehab should be for everyone. Even for me, I didn't have heart failure, but I found it so, and the average age in my class was 70, 65, 70. So I was the youngest by 30 years, 35 years. So I felt like a massive fish out of water. But it gave me the confidence as I said, it gave me the confidence to exercise in an insured environment where if things were going to happen, I was lucky they were going to happen there. And so the advice I give to colleagues is, as I said, make a blanket referral, and to patients, ask about it. The bottom line, I think, that patients forget, and doctors too, is that treatment for patients is a collaboration. You can't treat a patient without the patient being on board. If I give you a medication, I prescribe you a medication, it's no good unless you're going to take it. And so it's a collaboration. And so that goes, the same is said for cardiac rehab. And so, by saying to the doctor, hey, is there cardiac rehab I can go to? Some units I get don't offer it, but can you be referred to another hospital that does have it? So yeah, if your doctor's forgotten something, or didn't have time to mention something, ask.
Yes, that's great advice, and yeah, couldn't advocate more for cardiac rehab, because we do know that does improve outcomes. And Ange did touch on that in her article that was her blog that was shared this week as well. But yeah, some really good points there, Geoff. And yeah, I couldn't agree more around family, friends, and finding things that you love. Thank you for sharing your experience with us and your tips. We'll get you to jump in a little bit later on as well. But yeah, we might actually jump into the Q&A part now. So I'm very happy to introduce these very special guests. We're really grateful to have Arthur and Ange join us for this session. So Arthur is the Director of Acute Cardiac Services at Monash Heart in Victoria. He's a clinical associate professor with the Department of Medicine at Monash Uni. He serves as the co-chair of the Victorian Cardiac Clinical Network for the Department of Health and Human Services. He's an all-round nice guy, and he's kindly volunteered his time to share his expertise in heart health with us. And Ange, who some of you may know, so she had her blog shared this week, and she was diagnosed with cardiomyopathy in her 30s. She's since joined the Supporting Young Hearts group, or the Supporting Young Hearts Wolfpack, I should say. A strong advocate for young patients about, making sure you're informed and empowered in your care. So she's actually going to lead the Q&A. So keep in mind, we have collated all the questions. Obviously, I did mention earlier, we couldn't include everyone's question. I do apologise, but there is the helpline, which is available as part of the Heart Foundation, that you can jump on and give us a buzz. Otherwise, we will send out some information afterwards. But also, we do have the chat as well. So if you have any questions, please pop them in the chat and we will try and get to those as well. But I'll hand over to you, Ange.
Thanks, Pauline, and thanks for everyone that's made it to the event today. I'm really pleased to be asking these questions on your behalf, and there were lots of great questions that came through, so thank you to everyone for submitting them. And like Pauline said, if you've got questions as we go, just pop them in the chat and we will pause and have time to have a look at those as we go along. So welcome, Arthur. It's great to have you here. There's lots of questions for you, so hopefully we're not going to bombard you too much. But I think just to get us started, we've had a lot of people wanting to know exactly sort of how their heart works, and wondering if you could explain that for us.
Sure. Thanks very much, Ange, and also thank you, Pauline, for that very kind introduction. What you didn't say is I work very closely with Pauline at Monash, so our loss is the Heart Foundation's gain. So it's fantastic to see you, Pauline, involved in such wonderful initiatives that are really, I think, invaluable in helping heart patients. So thanks very much for having me, and thanks for your question, Ange. So look, the heart is basically a powerhouse that we can't live without, right? So the heart is a really simple but complex organ. It's basically the size of your fist, sits basically in the middle but slightly to the left side of your chest, and its job is to pump oxygen around the body via blood. So blood carries oxygen, and our body needs oxygen to survive. So every organ, every cell in the body needs oxygen, and it's the heart's job to get that around. And, you know, the heart beats 100,000 times a day, and it pumps over 7,000 litres of blood around the body a day. So when you just step back and think about that, and you have to think about the fact that it does this for 40, 50, 60, 70, 80, 90, 100 years in some people. I mean, you know, I don't know any Swiss timepieces that last that long. It's really a really unbelievable organ that really, even if it stops beating for 1 or 2 minutes, you know, not compatible with life. So this picture shows the heart's relationship with the lungs, which is really important, right? So what you can see is that the heart basically sits between the lungs, and the right side of the heart receives blood without oxygen in it that's been used up by the organs of the body. And then, so via the lungs, which take that blood, then it gets the blood, once it comes from the organs into the right side of the heart, gets pumped out into the lungs. Now, in the lungs, it undergoes what we call gas transfer. In other words, we breathe in oxygen, which comes into the blood. We breathe out carbon dioxide. And then that blood that now has oxygen in it from the lungs goes into the left side of the heart. And then from the left side of the heart, it gets pumped out of the aorta. And then from the aorta, it goes to all the various vessels and organs of the body, including the heart itself. So the heart's quite interesting from the point of view that it actually supplies blood to itself as well, and you know, we can touch a bit on that. So in a nutshell, that's what the heart does, and it does that in a pretty complex way. And if you want to click onto the next slide, Ange, I can sort of talk a little bit further about the intrinsic structure of the heart that makes sure that blood flows the right way. So on the left of the picture there, you can see a big vessel called the superior, and on the bottom, the inferior vena cava. So that's the big vein that actually receives blood from the body. And then from there, it goes into the right atrium, which is the chamber that receives the deoxygenated blood, or blood without oxygen. Blood then goes across what we call the tricuspid valve, which is the valve between the right atrium and the right ventricle. And then the right ventricle pumps the blood into the pulmonary artery, which is basically the artery that goes to the lungs, where gas transfer can occur. The blood can get oxygen in it. And then from there, the blood goes back into what you can see just below the pulmonary artery, the purple one, which is the pulmonary vein. So that you now have oxygenated blood coming into the pulmonary vein, which goes into the left atrium, which is the filling chamber on the left side of the heart. And then from there, blood crosses the mitral valve into the left ventricle, which is arguably the most important heart chamber, although they're all critical. And from there, you get pumping, and the blood will be pumped out of the left ventricle across the aortic valve into the aorta, and then into all the blood vessels around the body. So in a nutshell, that's how the heart is structured, and that's how the heart works. But there's really three key components to the heart itself. One, I suppose, is the muscle and tissues, and that's what you're seeing there on the screen. The heart muscle, which pumps, and the tissues which make up the heart muscle. But the second thing, and if you click onto the next slide, it's the plumbing, or the arteries. So the arteries, as I said before, are the vessels that actually supply oxygen to the heart muscle itself, and they come off the aorta. So you can see that big vessel at the top, which is the aorta. So once blood is pumped out of the heart into the aorta, it actually goes down into these coronary arteries. And these are basically the vessels that supply blood to the muscle. And when you hear about heart attacks and coronary artery disease, and that's something we may all have heard of, even if it hasn't affected us all, because it's actually the most common cause of death in Australia, and it's a really common cause of morbidity in the world. So that's one really critical part of the heart, is the actual arteries itself, that it needs to actually work. And then the next thing it needs to work, if you click onto the next slide, is the nerves or the electrical system. So it's not enough to actually just have a pump and just have a blood supply. You actually also need coordinated contraction, and that coordinated contraction comes from the nerves. And there's an intrinsic activity within the nerves of the heart that makes sure that the heart beats at a certain rate, which is usually between about 60 and 100 beats per minute for most people. And there are other nerves like the vagal nerve and sympathetic nerves that can make the heart beat faster or slower, depending on various situations such as emotional stress or fright or exercise. So, that's what controls how fast the heart beats. So, I mean, I could go on, but in a nutshell, you think of the heart as a pump, the nerves and the pipes. Putting that together, that really forms the foundation of how the heart works and where things can go wrong in the heart itself.
Thanks, Arthur. I mean, it's pretty clear it's a very complicated organ. As you said, it's like a very complicated Swiss timepiece. So, yeah, there's lots going on there. But I just wonder, you touched on heart disease. And so I was just wondering if you could take us through the main causes of heart disease.
Yeah, so look, heart disease it's a really broad umbrella term. It's basically any condition that can affect the heart. So again, in a nutshell, I just like to think about heart disease in each of those three different things that can be affected. So I already touched on the pipes or the plumbing. So if you have a problem or narrowing or blockage or tear in any of the pipes or plumbing, that can cause what we call coronary artery disease, which is really common. So most people, when they talk about heart disease, they probably refer to that. But it's much broader than that. Then we talk about the nerves or the electrical system of the heart, and dysfunction of the nerves, if you like, can cause arrhythmias or dysrhythmias, and that's when the heart can beat irregularly, it can beat too fast, it can beat too slow. In the worst case, it can even stop beating. So you can have primary problems with the electrical supply of the heart. And then the third area, which is another huge area, is problems with the pump itself. And the problems with the pump itself can really be diverse. So, for example, the left ventricle itself might become weakened, so that's called a cardiomyopathy, or a type of cardiomyopathy, so you might not be able to pump out as much blood as you can. The valves may narrow, the valves may leak, the arteries themselves may be plugged into the wrong places. There can be holes across chambers of the heart, which mean that blood doesn't flow in the right direction. The heart muscle itself can be thick, and that can predispose to other problems as well. So, there's that whole group of conditions that can affect the muscle itself. So, again, it's a really abbreviated way of saying the heart can be affected in lots of different ways, but if you sort of think about it in those three areas, that pretty much covers the spectrum of things.
Yeah, great. That's a really good summary. I guess one of those things is, these conditions can develop over time, but we do have a few people in the group with congenital heart disease as well. So how is that different?
So congenital heart disease just means heart disease that's present before birth. So it's disease that's actually first detected either in utero or shortly after birth, and it's to do with the way that our heart is made up. So that's probably the difference between congenital and acquired heart disease. Acquired heart disease is heart disease that develops that we're not born with, but develops after we're born, and that can happen at any time from childhood all the way through to when we die. So that's the main difference. But it's when you think about congenital heart disease overall, it's not, as cardiologists, it's not the most common thing we see. About 1% of people born certainly have congenital heart disease. So from that perspective, it's common. The most common type of congenital disease is in fact heart disease. So we 1 in 100 people do have it. But it probably doesn't make up the majority of heart disease, because a lot of heart disease really depends on lifestyle. Not all of it, but a lot of it is lifestyle related. And, in the last sort of 30 or 40 years, we all understand, and one of the main missions of the Heart Foundation is to improve heart healthier lifestyles, which is why we've seen a previous rise in rates of heart disease. But But yeah, so congenital heart disease that is there before we're born.
Okay, thanks. And something that's probably quite relevant to everyone listening is, how often do you see young heart patients? And do you think there's an increasing trend in younger people developing heart conditions?
So look, me personally, I would say that young heart, I define young as under 40 because I'm 40. So, to me, the definition of young is everyone sort of under younger than me. So I think anyone, so if I think about patients under the age of 40, that probably makes up maybe 15 or 20% of my practice. So it's not a big part of my practice. And amongst those people, there are lots of people who have symptoms of heart disease that don't necessarily have heart disease itself. So that's another thing we can get onto later. But having said that, I'm not a congenital heart disease specialist. I'm, I suppose, an imaging and general cardiologist who does a lot of risk prevention work. So that's probably why my ratio is a bit lower than others. But, if you had a congenital heart disease specialist on here, they might say that 90% of their patients are young. So yeah, I suppose it's who you ask. Second part of your question was, is it becoming more common? The answer is yes. So overall, we are seeing that rates of heart attacks and survival from heart attacks is getting better. But we are seeing a slight increase in people under the age of 40 having heart attacks. And it was, in fact, a study presented at an American conference I was at last year that actually went into that in depth. And the thoughts behind that really relate to lifestyle. So especially in the US where this study was done, there's really high rates of obesity, poor dietary intake in younger people, early onset diabetes and other risk factors, and that's probably accounts for that. So I think when we talk about coronary heart disease, we are seeing an increased rate. I think a lot of the other types of heart disease, especially congenital, cardiomyopathy, electrical, probably not a big difference in terms of trends.
Well, that's some really good background. It's quite interesting to hear that. I guess just going back to sort of technically how the heart works now as well. So what causes a cardiac arrest?
Right, so cardiac arrest means that the electrical system of the heart stops, and as a result, if the heart's not getting electrical signal, the heart itself stops beating. So if the heart stops beating, we drop, we can't function, blood doesn't get anywhere in the body. So that's what a cardiac arrest is. Now, what causes it? There's lots of things that can cause it. And again, it goes back to what I spoke about in terms of different types of heart disease that can happen. So one common cause is heart attack itself. So if you have a blocked artery acutely, so if one of the arteries blocks, which means blood can't get to the heart muscle and the heart muscle can't work, that can cause an arrhythmia, the nerves to stop working, and people can go down. There's scar in the heart due to a previous heart attack. That can be a focus of arrhythmia that can make the heart stop. Some types of cardiomyopathy. So for example, the most common genetic disease that we see is called hypertrophic cardiomyopathy. I'm not sure whether that affects anyone, but it's about 1 in 500 people have hypertrophic cardiomyopathy, and that's an autosomal dominant condition, which means that if one of your parents have it, you have a 50% chance of getting it yourself. So that is a type of heart muscle thickening that can cause cardiac arrest based on how it affects the arrhythmia and the electrical supply of the heart. And then of course there are so any condition, so whether it be a valve condition or a congenital condition that causes strain of the heart muscle itself that can predispose to these arrhythmias forming, can cause a cardiac arrest. So this is what makes heart disease so devastating in a way that you often don't get a chance to come back from a cardiac arrest, which is why what we do is often very acute and sometimes not forgiving. And that's why things like knowing CPR, having defibrillators in sporting clubs and in schools and things can potentially make a difference, because beyond that there's not really a lot you can do to come back from a cardiac arrest.
Yeah, thanks, Arthur. It is definitely something that's you're very lucky to pull through from, and we do have a few people in the group that have been in that scenario themselves, so I'm sure they understand firsthand. I guess next is sort of, you've mentioned there's a few things, a growing trend in some sort of heart diseases. What do you think can be done to help prevent heart disease, and things that we could be doing for ourselves to protect ourselves for future heart events?
Yeah, look, another really important question, Ange. So I think the most preventable type of heart disease is probably coronary artery disease. And like I said, that can affect people, young people these days. You know, we've seen people as young as in their late 20s having a traditional type of heart attack where they get plaque build-up in the arteries, blocks the arteries and reduces flow. So that's something that there's absolutely an opportunity to intervene on early. So the basic things really there are firstly not smoking, and that means not smoking, not vaping, not using recreational drugs, not using illicit drugs. All of those are known to affect the coronary arteries and increase the risk of heart disease and heart attacks. Second thing is having a healthy lifestyle, and that really, when I talk about a healthy lifestyle, there's really three aspects to that. The first is exercise. So, you know, at least 30 minutes a day, 5 times a week would be the minimum of what we'd recommend. But beyond exercise, it's also being physically active. So it's really been pleasing as a cardiologist to see personal activity trackers becoming a lot more common now, and everyone having their Apple Watches and their Fitbits and counting their steps, because I think separate to exercise, aiming for at least 10 or 12,000 steps a day has been really shown to reduce risk of heart disease. So really, you know, it's avoiding that sedentary behaviour. So it's standing more, walking more. I say that as I'm sitting in my chair, really I should be standing. I wonder how many people are actually standing now. I mean, whoever is, you know, kudos to you, because really that's what we should be doing more. And, you know, I've heard people describe sitting as the new smoking, and I can sort of see how that is when you look at how it increases risks of heart disease. And then the third aspect of lifestyle is diet. I won't go into that in depth. I mean, there's so much available on the Heart Foundation website and the like, but, you know, that can really reduce chance of heart disease later. And then there's managing and knowing your numbers and your risk factors. So, you know, the big three are hypertension, which is high blood pressure, high cholesterol or hyperlipidemia is the second, and the third is diabetes. So, you know, from sort of probably your 20s on, you should all know what your blood pressure is, you should know what your cholesterol is, you should know what your sugar is, and do things to keep those under control, because we know that years of high cholesterol or high blood pressure or high sugar can absolutely contribute to that risk as well. So, so in a nutshell, they're probably the modifiable risk factors, if you like. There are some other specific things to specific conditions, but yeah, I probably won't go into specifics unless anyone's got any other questions later.
We have just got one that's come in from the group, which I think is quite relevant. We were just touching on cardiac arrest. So here Goran's asked, can scar tissue as a result of heart surgery increase the risk of future cardiac arrest? Yeah.
The really brief answer is yes, but scar tissue is a really complex thing. So there's two types of scar. You can have what we call regional or focal scar that can happen due to a primary problem in one part of the heart. So for example, you know, a blocked artery, or, you know, a complication of surgery in one part of the heart. That can increase risk of arrhythmia and cardiac arrest, but then you can have more generalised or diffuse scar due to generalised processes like hypertrophic cardiomyopathy, for example, which probably in some instances doesn't increase risk as much, but can also increase risk. So, so the short answer is yes, but having said that, the absolute increased risk may not be so great, and really to measure that, you have to do tests like echoes, which are heart ultrasounds, or cardiac MRIs, which are really the only cardiac tests that show burden of scar. But we are using cardiac MRI and really measuring scar much more now than we used to think about whether we need to put defibrillators in people to I suppose avoid dangerous arrhythmias and treat dangerous arrhythmias to minimise risk of arrest. So it is something that cardiologists think about, and I think I would advise the person asking that question to, if it's a personal thing, to ask their cardiologist, you know, have I got scar in my heart? You know, is there anything that can be done to reduce risk of cardiac arrest as a result of that scar?
Great, thank you. We've also got another one. I think we've got time for questions that are coming through. So this one is, when consulting with younger people with heart disease, do you find there's a difference in behaviours and interaction with your patients when compared to older people?
I do, and I really enjoy it, to be honest. And I think the major difference is that I find that in general, I'm speaking very generally here, I find younger people a lot more educated and engaged in their heart disease than older people who tend to sometimes just think that this is something that happens as I get older and, you know, I'll do as you say. So So I find that younger people, as I said, know a lot more about their condition. They come and they bring me a brochure of something they've read and ask a specific question as to how that relates to their particular condition, which I really enjoy doing, because sometimes they're way off the mark because what they've brought to me has nothing to do with their condition. But at other times, and there's been instances where it's made me think about things a lot more than or in ways that I otherwise wouldn't have. So I do think in general that there is a difference, and they're just some examples of how.
That's great, thanks. Were there any other questions that popped up, Pauline? I've caught a couple.
No, you're on track. You're doing a great job.
Okay, cool. So if we want to just keep moving then, what we're going to do now is, what are we doing next? Oh no, we're still asking questions, sorry. I was just reading my notes here. So yeah, we still have a few more questions to go through, formal questions that were submitted beforehand. So we'll keep tracking through.
Sorry, guys. Just quickly back to the scar tissue question that I asked earlier. So basically, I think what I was after with that question is, when someone has open heart surgery and the heart is cut into as a result of that surgery, that scar and how I guess that's stitched up together and how that heals, is that going to affect someone long term? So just I guess it's a matter of more like the process of the surgery itself rather than I guess what they were doing in the surgery.
So the surgical scar, I guess you mean.
Yeah, I get. Look, generally the answer is no. Generally, right? Because the scars are pretty minimal, and they tend to be put in parts of the heart that aren't important for conduction and arrhythmias and the like. But again, I would sort of say what I said earlier. I would specifically ask your surgeon or cardiologist, if you have one, about the specific type of cut that was done in you. And there's a lot more that really is looked at beyond the actual location of the scar. So sometimes surgery itself can lead to other things like the heart muscle weakening or valves being problematic, which can increase the risk of arrest and arrhythmia much more than the actual scar of the cut itself. But generally, my general answer to that is no. We rarely see issues. If I step back and think about the number of patients who've had surgery with cuts into their heart in various parts versus how many of them have had a cardiac arrest, it's a very, very small number.
Thanks.
Cool. Thanks for clarifying that. Okay, so we've had lots of questions and we've spoken about a few of them about risk factors and warning signs. So I just sort of wanted to spend some time going through that specifically. Can you explain what the risk factors are for heart disease and which ones we can work on?
Yeah, so I think I probably touched on some of those earlier. So it's about, the main ones are the modifiable risk factors, because you can really split it into non-modifiable and modifiable. And the non-modifiable, we can't do much about them. So, the biggest modifiable, which luckily doesn't affect most people in this group, is age. As we get older, the risk goes up. You can't do anything about that. The other one is family history. So we know that, for example, coronary artery disease, there is a strong predisposition for that to run in families, particularly when it occurs at a younger age, which we define as under 55 generally. And again, you can't do anything about your genes and your parents. That's just something that you have to work around. And there are other specific risk factors in females, like for example having preeclampsia or high blood pressure or diabetes in pregnancy. We know that those factors can increase risk of heart disease later. So we can't do much about those things, but what we can do something about are the modifiable. So high blood pressure, high cholesterol, diabetes, smoking, physical inactivity, lack of exercise, the things I've touched on before. So it's all about the lifestyle things that I mentioned, and often medications. So, we haven't touched on medications yet, but, a lot of these conditions beyond lifestyle, which is always the first way you start by managing this, is really the medical therapy. And often lifestyle is not enough, and you need medications to lower your cholesterol or to lower your blood pressure or to lower your blood sugar. Or to help you stop smoking in some instances. So they're the other things that are often needed.
So, medication's an important one that both Geoff and yourself have brought up. So I guess what are the risks of not taking medication as prescribed?
Yeah, so again, it depends on what you're on them for. But if we continue what we're talking about, and that is, if you say you're on them to manage risk factors, then, you will develop risks of the condition that it's meant to be treating. So for example, if you're on tablets to lower your blood pressure because you have a condition which is at risk of recurring with high blood pressure, then you're at risk of having that condition. So if we take high blood pressure, for example, increased risk of heart disease, increased risk of stroke, in some people increased risk of tears in the aorta and other vessels, which we know can be associated with high blood pressure. So and cholesterol similarly, high risk of heart attacks, strokes, diabetes as well. So not taking medications will increase your risk of those conditions, but also other medications people are often on to manage symptoms of conditions. So if I take heart failure, for example, people might be on diuretics or ACE inhibitors to reduce build-up of fluid in their lungs or their legs. Again, if they don't take medications, there's a much higher risk that they will have decompensated disease, which can often lead to needing to go to hospital or doctors and the like. So I think knowing why you're on them is really important to, I think, help compliance.
Yeah, and I found that really an important part of my cardiac rehab sessions as well, actually going through and each of the medications and what they do for the body as a reminder, because you take on so much when you're in hospital and, being given certain medications. I definitely found that was really good to educate me and remind me of each one I was on and why. So that's important. I guess another thing that's close to my heart is, the heart and the mind connection and emotional health and well-being. So what do we know about the heart and the mind connection?
It's really strong, actually. So you can think of it two ways. I mean, one way is the effect that the mind can have on the heart itself. So stress is the big one. A lot of people come in and I'll say, there's a lot, especially in the last 6 months. I mean, this has been just the weirdest year that any of us have had, I'm sure. It's a lot of people are under a lot of strain for lots of different reasons, and that can lead to symptoms that might sometimes be unrelated to the heart. But we also know that stress can increase risk of heart disease, and whether that be acute stress or chronic stress in various ways. So I suppose you've got that aspect of the mind-body connection of mental health and the mind increasing risk of heart disease. But then the other way around, in other words, people have a heart event that may or may not be sort of stress-related or stress-induced, and then the effect that has on their mind and their mental state and their emotional well-being, as you've touched on. So, we'd call that, in acute phase, we call that the cardiac blues, which we know a lot about. And I think, there's a group called the Australian Centre for Heart Health, as well as the Heart Foundation, who've done some tremendous research in this area that, we've been lucky enough to be involved with at Ange. So I think, that's a real thing. And when that's something we see, and to be perfectly honest, I don't think we manage well as cardiologists. I know that, our nursing staff and our social workers pay a lot more attention to this than we do. But that just means it's the emotional state that you have after an event, whether that be acute or acute on chronic. And, that can be, you might be sad, you might feel guilty because you might think, if I didn't smoke, this wouldn't have happened, or, you might feel anxious or unsure about what's next. And, in most cases, that the cardiac blues or that emotional adjustment often just does get better with time, but sometimes it doesn't. And that's what we really need to watch out for, because that can develop into depression or more significant mental health issues. And, there are cardiac psychologists that work with us, and we can involve in the management of some of these conditions. And often it's just a matter of understanding and talking through a lot of these problems, but sometimes, medications could be needed as well.
Yeah, thanks, Arthur. And while we're talking about different mental health conditions as well, we do know that anxiety is quite a common theme, and sometimes the symptoms of anxiety can mirror the symptoms of a heart attack or a heart event as well. So how do we sort of differentiate between the two, or are there some ways that we can do that?
Yeah, that's a great question. So, and it's something we face really common. It's a regular thing that we deal with as doctors. People coming with chest pain, and it's about sorting out, what's the cause of chest pain. So, the first thing I'd say to people is if you have chest pain, even if you're not sure what it is, even if you think it's probably anxiety, get it checked out. I mean, that is by far and away probably the most important thing I can say regarding that, because there's nothing better than a false alarm, nothing better than false alarm. You know, and also that can relieve anxiety, because, you know, if you're not sure what's causing it and you come in and you're told it's not your heart, then that can in itself be the therapeutic thing that you need. But in terms of how do you differentiate between it, again, just to re-emphasize, I don't think that's something that, you know, we as individuals, people should be doing. I think, you know, leave it up to the doctors to do that, because I think it's often impossible to do without some more assessment, examination, and some basic tests. But what we would do if faced with that, you know, we would ask about the type of chest pain. So, you know, for example, a stabbing discomfort that's very brief and transient, especially after a stressful situation that comes on at rest, is more likely to be anxiety than heart disease, especially if it's associated with sort of numbness around the lips, you know, the heart beating quickly. Sometimes people get tingling, you know, sometimes people say, you know, I can't get a big breath in, I can't, you know, I feel like yawning. Those sort of things are probably anxiety-related discomfort that people can feel, as opposed to the other extreme where someone, you know, says, I feel like an elephant sitting on my chest and I'm sweaty, or, you know, every time I walk or get my heart rate up, I get a squeezing sensation that gets better as I rest. You know, the other end of the spectrum, clearly, you know, not going to be anxiety. But, you know, we look at that, we examine to look for physical signs of heart disease, and then we'd run really basic tests, you know, which I'm sure a lot of people know about. So an ECG would be a routine thing to work out why someone might have chest pain, whether they've got anxiety, you know, and then sometimes you might do a stress test or other imaging to try and work that out. So that's sort of how to do it. But as I said, I think always, and this is what I always say to people, err on the side that it is serious and hope that it's not, which usually it isn't, but that's the best way to go about it. And the other way around, which is ignore something that is potentially serious and then have to deal with the fallout of that later.
Yeah, thanks. So if in doubt, always ask, and I guess keep asking until you're sure that, you know, if things are reoccurring or you're not 100%, then yeah, keep seeking those answers. That's really cool. Okay, the other thing we've touched on quite a few times, you've mentioned diabetes as well, so as a sort of something to watch out for. So if you have diabetes, what should you know about heart disease, or what should you be aware of?
Yeah, diabetes is a really important condition. You know, and two types, type 1, which is where your body can't make insulin, and type 2, which, you know, more the lifestyle disease. So type 1, more younger people, maybe some people of this age where, as I said, your pancreas can't make insulin. Type 2, where, you know, because of lifestyle or other genetic factors, your body can't respond to insulin. So you have what we call insulin resistance. That can lead to build-up of circulating blood glucose, which can deposit in our blood vessels everywhere. So heart's one, so it can cause coronary heart disease and lack of blood flow through the arteries and increased risk of heart attack. But similarly, it can deposit in other big vessels in the head, increased risk of stroke, in the kidneys. It can even deposit into small vessels, so behind the eyes, for example, and lead to visual problems, in nerves and cause tingling of nerves and the like. So, And that can, and the rate of all those complications, that's what we call these complications of diabetes, is markedly increased if your sugar is not well controlled, right? So we know that people who've got very well controlled sugars often don't develop any of these complications. I mean, just yesterday, Friday, I saw a patient who was age 61 who was diagnosed with type 1 diabetes over 40 years ago. We had some funny chest pain. We did some tests. He had no coronary plaque at all. I was just so pleased to see that. It was just a really good example of how, you know, and this guy, you know, was really managed his symptoms and his heart disease well. But it's an example to show that, you know, if you manage your sugars well through lifestyle, medications, insulin, or whatever is required, you can really avoid a lot of these complications that are associated with poor control of blood sugar. And if you see a kidney specialist, I'll say exactly the same thing that I'm saying. You'll have less chance of kidney problems. Or if you see a neurologist, or if you see a stroke specialist. So yeah, so diabetes, increased risk of heart disease and other vascular and non-vascular disease, but very markedly reduced rate of complications if sugar is managed well.
Great, thanks. It's been really comprehensive. Just going to check in with Pauline now. Have we got any other questions from the group that have come in?
We do have a few in the chat, so we might get to them with some of the correspondence, but I thought it might be a good opportunity to bring Geoff back into the discussion, because there was a few more questions sort of focused on being a doctor and a cardiologist. So are you happy to take?
Yeah.
You happy to jump back in and Yeah, Ange,
Sure.
take it away.
Great, cool. Thanks, Geoff, for jumping in. So I'm going to ask a few questions for both yourself, Geoff, and Arthur. But I'll ask you first, Arthur. Why did you choose to become a cardiologist, and what makes you passionate about heart health?
I mean, I'm almost embarrassed to answer this after Geoff, because I mean, you never want a reason to be a cardiologist. You know, you hear Geoff's story and you get tingles down your spine. So, you know, nothing will compare to that answer. So I'm just happy that I heard that story. But look, I loved science. I loved, you know, I remember being asked this question when I did my medical interview, and they said, "Why do you want to do medicine?" And I said, "Look, I enjoy science, and I think the human body's fascinating. I'd just love to learn more about it, and I think I'd be good at it." I didn't know that I wanted to do cardiology at that time. But as I started studying all aspects of medicine and really started seeing patients, I really became drawn to the heart very early, and probably within a year or two, I knew that's what I wanted to do at the expense of other things. And I suppose the main reason was that it was really common, so there was a lot of heart disease around. It's very evidence-based, and this should give everyone a lot of sort of heart, pardon the pun. You know, a lot of our treatments are based on really good trials and evidence. And as a student and studying and as a young doctor, I remember just, you know, why do we put people on this particular drug for this condition? Well, we've got all these trials, as opposed to other specialties where a lot of it is done on, I suppose, gut feel or expert opinion. So that, I think that really scientific and evidence-based nature really drew me to it. And probably the other thing was, cardiology has a really nice mixture of procedural work and intellectual work, which really, you know, was appealing to me. So you can really be a thinker and do a lot of the physician type stuff, which I find really rewarding, but you also can make immediate differences in people with various procedures where they come in with a cardiac arrest or a heart attack, and 40 minutes later they're sitting up thinking, you know, what's all the fuss about? So you really can see that dramatic change. So they're the sort of things that drew me to cardiology, I suppose. But what makes me passionate, you know, you can probably tell by the way I'm talking. I mean, I just think there's so much more we can do, and it's so common and it's preventable. And I think, you know, events like this where we can get the messages out and help people take control of their cardiac risk factors is probably what drives me. And I think as I'm sort of getting a bit older and more experienced, I'm really trying to shift a lot of my practice towards more prevention than cure. And I think if there's one thing I sort of want to do more in the next few years, it's that, to be fair.
Yeah, great. Thanks for sharing. And Geoff, I guess we touched on your reasons earlier, obviously having personal experience, but was there anything else you wanted to add to what encouraged you to become and follow this path to become a cardiologist?
Yeah, I mean, I guess for me, it wasn't a choice of I want to become a doctor. It was a choice of I want to become a cardiologist. So it's actually been difficult through these I'm now 5 years into my medical training, 4 years of medical school. So I'm 10 years after I decided to become a cardiologist. I'm not there yet. It's exhausting, but anyway, that's okay. But I, you know, it's I think that the thing I wanted to say was that I actually have a lot of respect for people who aren't in a way lucky enough to have had the personal experience that's driven them to become a doctor or to become a cardiologist. Because yeah, I'm in awe actually of people like Prof, and I'm not about who've had that desire without having the intrinsic, you know, something drive them, because for them it's about other reasons to want to become a cardiologist or become a doctor. And so I actually I'm equally in awe of people who have had that without, you know, having the personal experience, because the personal experience for me has driven me and continues to drive me. Yeah, I guess I knew that I was so lucky after my first open heart to have survived it. I just really needed to utilize that luck, you know, to in the same way that Prof mentioned, to try and help it from happening to others and prevent it from happening to others. So
yeah,
that's all I want to add. Yeah.
So that's what's got you through the 9 years so far.
Exactly. Yeah.
It's that commitment to just keep going.
Yeah, and actually on that note, you brought something up too. I mean, I've got another 4 years to go, all going well. You know, unaccredited years and 3 years of advanced training, which I'll be more than happy to do at my shot. But the thing I wanted to, I've loved the journey, you know, and you couldn't love the journey, you know, it's 14, 15 years, you couldn't love the journey. So you couldn't do it without loving the journey. And so every day you wake up and you think, gee, I'm lucky to be A, alive, and B, do this job, and C, you know, help others in the way that, you know, I was helped. So that's a fantastic, you know, kind of feeling to know you wake up and you can have that effect on people. And I just feel lucky every day that you know, this journey is carrying me and I'm still alive here to live it.
That's fantastic. Yeah, and we're really happy to have you as part of the campaign and as part of the group, because it really just brings something so amazing to the group. So thank you. I guess, well, while I'm speaking to you, Geoff, I'll direct this one to you and then we'll go to Arthur.
Yeah.
But what do you find the most challenging part of your job and why?
I think that having had other careers, or, you know, another career, you know, it's just about making money. You know, obviously that's important, but the game's when you're doing medicine, the game, it's not about money. The game is about lives. And so every day, the decisions you make are life or death for people. And here we are talking about, you know, one day in some cases, one day in our life, which has changed us forever. But I still remember the doctor. I still remember the surgeon. I still remember the discussions we had on that one day 10 years ago. I still remember the nurses, you know, and so the challenging thing is to recognize that every day you're a doctor, you're having this profound lifelong effect on people, and that whilst you've got to do it with humility and with humor and with kind of compassion and empathy, you've also got to be serious, and because, as I said, these are people's lives, and so I find that the hardest thing is every day, as I said, you're making decisions which affect people's lives, you know, for better or worse, and that's a bit of a challenge. It's a challenge I enjoy, but that certainly would be the probably biggest challenge. Yeah.
Yeah, thank you. And Arthur, just quickly over to you. The same question.
Yeah, so I would echo a lot of those comments, actually. It's interesting that, you know, Geoff's already experienced that after only sort of, you know, doing a couple of years of basic training. But it really, I mean, to me, professionally, the hardest thing is really having those difficult conversations with families. And a few just stick in my mind, like that happened this morning, that, you know, happened so many years ago, where, because it's because a lot of these events are devastating and come out of the blue. And it's, you know, talking to the children or the spouse or the partner of, you know, an individual who's sitting up, you know, having dinner with them, who, you know, 90 minutes later, you're sort of having to say, look, we just couldn't get them back from their arrest. So for me, by far, that's the hardest thing. And, you know, fortunately, it doesn't happen regularly, but it does happen. And I think that's what I really find difficult, because, you know, we're all humans at the end of the day. And as much as you have to, for your own sanity, divorce yourself from that to some degree, you know, you always feel for people. So I think that is by far the most challenging part of what I do, I would say. And probably the other thing that's happened, I mean, you know, on a more personal level, as I've got a bit older, I've got 2 young kids now, and you know, I think that there are times where work can get really busy, and as much as you really try and prioritise spending time with your family and your children, sometimes you just can't, because you've got those pressing demands from work, and a lot of them are unexpected. And, you know, you might be planning to get home at 5:30, but, you know, when you get that call saying, look, someone really needs to be seen, and you know, you don't. So it's trying to find that balance, which, you know, it's something I don't think I'll ever work out fully, and I don't think any doctor will, but it's something that's always there that you have to really juggle with. It's really looking after yourself and your family and the people you care about, and your own mental health, as opposed to looking after your patients.
Yeah, thanks. Pauline, I might just see if there's any questions that the team want to ask Geoff or Arthur before we continue. Just putting it out there if anyone's got any questions.
I have a question.
Go for it.
So earlier on in the year, my cardiologist, I've had my echo and all that kind of stuff, and my heart function I had heart failure cardiomyopathy. I was diagnosed 4 years ago, and my heart function is back to normal, and they said that they feel like I have recovered from cardiomyopathy. But my cardiologist still wants me to take my cardiac meds. Is there a reason why? And the other question that I have is, now that I've recovered, is there a possibility that I can relapse?
I'm happy to answer that, Ange. I'll answer generally. I won't specifically,
Yeah.
because I think without knowing things, but we do know that people who have weak heart muscles, for a variety of reasons, are at increased risk of complications, which is why we put people on medications. And often that does lead to improvement in heart function, and that's why we put people on medications. And for a long time, we weren't sure whether that meant we could stop the medications or whether we need to continue them forever. And there was a really important trial done last year that showed a very high rate of relapse when medications were stopped. Right. So in general, and depending on the condition, unless there's complications from the medications, there is definite benefit in continuing, sometimes lifelong, for cardiomyopathy. So again, I don't know your specifics, but that's something that we often see with cardiomyopathy and relapse later.
Like when you say relapse, like are you talking years later or? Like
it's very variable. In some people it can happen within weeks. In others it can happen within years. So okay. It's a very broad group of conditions that's quite variable. Yeah.
Okay. Thank you.
Thanks for asking the question, Pearl. Was there anyone else out there who had any questions? No? Okay. So Pauline... Oh, sorry.
Before you go on, sorry, just very quickly, I just had an email, someone had emailed through a question.
Great. Thanks, Jen.
And so it was just around exercise. And I know you mentioned it quite a few times, Arthur, about how very important exercise is for prevention, and then functioning for also after having a heart attack maybe or a heart condition. So the question was, just if someone doesn't so should people with heart conditions still exercise even if they don't enjoy it, as long as there's nothing as part of their, from their cardiologist or their health team saying that they shouldn't be? And like what is your advice around people getting back into exercise, or would that obviously be different for different conditions? But just around that exercise question. Yeah,
so again, it depends on the type of heart disease. So unless someone's really acutely unwell, or there's a risk of an arrhythmia, for example, or another condition being made worse by exercise, which is really quite rare, pretty much any other post-acute situation will benefit from exercise with heart disease, unquestionably. And in fact, that goes further. It's even people without heart disease with risk factors. Unquestionably, exercise will improve your life expectancy, even without heart disease. And your sense of well-being, emotional and physical. So exercise, I think, unless you've specifically been told by a doctor, do not exercise because your condition is dangerous for reason A, B or C, I think absolutely that should happen. And look, within that, there may be some types of exercise you can't do. So for example, if you've had open heart surgery for a period, you may not be allowed to do resistance training, or if you've got a type of cardiomyopathy, you may not be allowed to do contact sports. But usually, aerobic exercise is fine for everyone. And should you do exercise if you don't enjoy it? Yeah, absolutely. But what I would say is, try and enjoy it. So vary it. I mean, exercise can be anything. It can be putting on your runners and walking. It can be cycling. It can be swimming. When swimming, I'm in Melbourne. I'm not sure who's lucky enough to be in Melbourne, but at the moment, we can't do much more than walking around the block. But when that opens, go to the gym, go to the park, walk your dog. There's really so many ways you can spice it up. And I'm not an exercise physiologist by any means, but I think I would strongly encourage people to exercise whether they enjoy it or not. And if you don't, you think of it as, it's like taking your medicine. I remember when I was a medical student, there was a GP that I worked with who actually used to write on a bit of paper, like on prescriptions, this is your exercise prescription. And he would say, you've got to do this for five times a week for this long. And he would hand it to the patient. So if you think about it like that, it sort of might emphasize its importance a little bit more.
Thanks.
I've got a question. just on reducing heart disease, or future episodes regarding certain types of foods. I've had a sort of family doctor that's done a bit of research with American studies in certain colours of foods, helping reduce future episodes, or things like colours of reds, blues, purples, blacks, containing, I think, also having vitamin K within your diet, or getting vitamin K and chilies and stuff like that, certain types of chilies.
Yeah, okay. Colour is interesting. I mean, I must say, the main thing I can say about colour is whole grain is good. Brown is good. So, whether that be pasta or rice or, or bread or anything, I think, whole grain clearly has been shown to, reduce risk of cardiovascular disease, diabetes, gut problems as a source of fibre compared to white foods, which really tend to spike your insulin and increase risk of complications. So not much doubt there. Fruits and vegetables, I mean, we all know about the importance of having our serves there. Again, maybe the vitamin K you find a lot in leafy green vegetables like spinach and broccoli and, bok choy and that sort of thing, which is very good for you. So, I haven't thought about it in that way, but yes, that's a really good source of vitamin K. So that for sure is important. Fish, really important. So getting a good diet of oily fish, which we know, can raise your HDL in some instances. And that's often good. And the corollary of that is avoiding red meat. So if you're talking about red, we know that high rates of red meat can increase risk of heart disease, bowel cancer and the like. So really limiting portions there. And then, dairies and things, low fat, avoiding sugars, avoiding trans fats, the common things we all know about. And it's not about avoiding fats altogether, because we know that things like avocado and nuts and things that, might be calorie dense can in fact be, olive oil, can be cardioprotective in a lot of ways. So, and probably the only other thing I'd say about diet is salt, especially amongst the younger group, because I think, a lot of the public health messaging is, avoid salt, because salt, increases blood pressure, can increase risk of cardiovascular complications. And that's probably true for the majority of people, but there are certainly some people where I and we as doctors advise people to eat more salt, because salt can actually increase your blood pressure. And that's something you need to do in some instances. So in some people who've got, what we call a high vagal tone, or walk around with low blood pressures and feel dizzy and the like, a strategy to increase that without using tablets is to actually drink more water, eat more salt, use salt liberally in the diet, etc. So, salt's a bit of a two-edged sword, but in general, it's important to look at sodium and salt content of food as well. So, I don't know if I've answered your question, but that's the sort of broad sort of advice I give people with regards to diet.
Yeah, it was more on a doctor that had clogged arteries, and what he's stating is he's reversed these arteries himself over years of certain food types and certain colours within foods. It was just a family doctor explained to me to look into something like that, and the doctor states that he has reversed the clogging of his arteries over years. Yeah.
I mean, diet can reduce the rate of progression of clogging. I'm not aware, maybe I haven't seen it, but I'm not aware of any diet that can unclog arteries. But, I'd say, if it's something you want to look into, take it to another doctor or cardiologist and see what it's about.
Yeah. He was talking about there's a certain drink in the morning where there's apple cider vinegar, adding apple cider vinegar, turmeric into a concoction of a glass, a drink that you mix one of these spices in together, and it just helps with reducing it.
Okay. Yeah. No, I'm not familiar, but I'll look out for it.
I'm just going to quickly ask one of the questions that came through that I think is going to be most relevant to everyone just before we wrap up and go to the next part of the session. And that is
something about, sorry to interrupt, can I just mention something about the exercise, about the not enjoying it aspect, and something that actually Rachel brought up in the chat. And a line that I quite like is, the best exercise for you is the one you actually do. And so, it's a great little line, it's it doesn't matter what it is, it's the one you physically, you actually go and do. And two tips I find to make exercise enjoying is one of these, and you can compete with your friends who also have one of those. And on a weekly or daily basis, you can compete with whoever it is who's got one and meet a certain amount of calories or steps on any given day. And so that makes it fun. And the other thing too, which links back to something we talked about earlier on, is anxiety and stress. I mean, exercise, you know, for those who have trouble enjoying it, is proven time and time again to lower stress and anxiety. And you know, if you've had a stressful or anxious day, having even 20 minutes exercise, you know, in some cases is equal to taking your medication. I'm not saying don't take your medication. What I'm saying is that's what kind of benefits it's been proven to have had. So if you look at it, flip it on its head and look at it that way, you may find that you get more enjoyment from it.
Thanks, Geoff. That's a really important point. So the question I was going to ask is about COVID-19, and we've had a lot of people asking, you know, how does someone with heart issues stay safe at the moment, and what are your tips on navigating the COVID normal?
Yeah, so we're learning a lot more about it every day. So look, I believe that, you know, our biggest thing with COVID as individuals is that, you know, we're nearly all almost certainly going to be okay. When I say okay, you know, not going to end up in intensive care or die from it, you know, if we get it, right? But why I think we need to avoid it is because if we get it, we are potentially a vector to then pass that on to someone who may die of it, right? So the less transmission there is in general, the better. So, and I think that's why I really think, regardless of, you know, how healthy or unhealthy you are, you really must take a lot of the public health preventive measures so seriously. So, you know, in Melbourne, wearing masks, social distancing, hand washing, you know, all of this stuff is just so important to avoid, you know, as I said, being that vector that can potentially be part of that chain that does give it to someone who will get sick or die of it. So I think that's why I think it's really important to avoid it, you know, getting it. In terms of risk of serious complications from COVID if you have heart disease, it's a really difficult thing to answer because the answer is we don't know. I mean, no one's done any randomised or sort of detailed scientific studies looking at exactly what happens to people with COVID. I mean, when they've gone back and looked at people who've had serious complications of COVID, they have seen that those patients are more likely to have had high blood pressure or diabetes, or to be obese, or to have lung disease or types of heart disease. But a lot of the things I've read are not more specific than just heart disease. So, you know, someone who's got AF or someone who's got a VSD or someone who's had a heart operation, I mean, we just don't know is the bottom line. I think, you know, so, you know, a lot of my patients with all sorts of conditions ask exactly this question. And I advise them exactly what I've just said. And that is, you know, we need to take the measures that we all need to reduce the risk. But having said that, we need to balance that with living our life. And I think, you know, now that as we move to COVID normal, we need to, you know, get back to work, and we need to interact with our friends, and we need to do the things that we enjoy, because, you know, this will probably be with us for a while. And, you know, we're all crossing our fingers for a vaccine. But, you know, even if that comes, you know, it will still take a while for this to potentially be something that won't be so deleterious to everyone. So, so that's what I'd say about COVID. You know.
Yeah, I guess just on that point though, like, you know, I have cardiomyopathy, and I do know that the flu season, for instance, is always one that I think about every year, and I get my flu vaccine. So, you know, I do have some anxiety around, am I more compromised than the average person because of my condition? Yeah,
I mean, you know, with using cardiomyopathy as an example, I mean, you say someone does have a significant cardiomyopathy and they get COVID. If it's a mild COVID, the cardiomyopathy will be irrelevant because they'll just get over it, and it will be. But if they get a more significant COVID and they need oxygen, then that's where the cardiomyopathy becomes relevant, because you know, you need that ability to pump blood around the body, and that whole stress or inflammation of it can happen. So, you know, people that are, you know, and that's why you see 100, you know, there was a story about a 100-year-old patient surviving COVID. You know, they must have had a mild form. So there's so much we don't know about COVID. But yes, you're right. I mean, in general, if you have another condition that would put the body under strain, if you did get sick, or make it harder for the body to deal with, that would increase risk of complications. But But having said that, yeah, it's just as likely that you'd sail, or someone with cardiomyopathy would sail through it completely fine.
Great.
Amazing.
Thanks.
Thank you. Thank you so much. Thank you, Ange. That was superb. Everyone give Ange a clap. She did an amazing job. And I know she was really, really honoured to be asking the questions on behalf of you all. And yeah, a massive thank you to Arthur, for, sharing us, you're loaning us your time today and sharing your expertise. As I said, he's, all round great guy, and it's really nice that you're able to engage with this group. And I know we really appreciate it. And also Geoff as well, just your unique perspective. I think, your story is very touching to all of us, and, we're all here behind you, supporting you to get, to the cardiology program, at Monash Arteries, apparently. And thank you. There are some questions in the chat, so the chat will save, and we are going to endeavour to get to everyone's questions. We obviously didn't get through everything, but now we're just going to launch a quick poll for everyone. Just to get a bit of feedback about the session today. And then after that, we're actually going to move into breakout rooms. So if you want, I'll just give you a few seconds just to go through the evaluation questions and answer them. And then I'll explain the breakout rooms to you guys. So the reason that we do this is just kind of with the evaluation is just kind of get a bit of an idea. I mean, there was some comments in the chat maybe about doing some dance classes and nutrition classes together. Heart dancing, I think it was. I like that. So yeah, we really aim to make sure that these programs are what you guys want. So it's really important to us that, if you give us any ideas, if you don't do it via this today, we'll send you out some correspondence in a couple of days, or you've got Jen's email, or you can find me at the Heart Foundation as well, and just let us know, what you think would be helpful for you, because, we are here to support you, as young heart patients or heart patients in general. And I think
absolutely. Thanks, Pauline. I second that completely. And we're very open to feedback and ideas. Anything that you want to share with us, we would love to hear from you, and really make this, like I had on one of my slides, I think that this was developed by young people for young people, and we're just here to help, connect those dots and link people with each other. So please don't hesitate to reach out.
We are the conduit. Now, in a sec, you're going to get a message that will come up, and it'll come from Kelly, just about a breakout room, to join a breakout room. And what it will have is just an option for you to choose which or select which breakout room you go into. So they're based on your heart condition. So it's basically just a way that you can connect with other people who've got a similar condition, and therefore, just share your story. Our advisory members will be in those groups as well.